Hello, this is my presentation on the medicated child and prescribing medications to young children and adolescents. Bipolar disorder is a mental health disorder that can be defined by the DSM-5 as a group of brain disorders that cause extreme fluctuation in a person's mood, energy, and ability to function. BPD generally appears in late childhood, adolescence, and young adulthood, and the earlier the symptoms appear, the more severe the psychotic features, higher comorbidity, and poor clinical course can be. A select few medications have been approved by the FDA for children used for treatment, which include haloperidol and thyroidazine, and a few more. Haloperidol and thyroidazine are classified as first-generation antipsychotic medications that were originally developed in the 1950s to treat adult psychotic symptoms. However, now they are rarely used due to the severe number of debilitating extrapyramidal adverse effects like tardive dyskinesia that is often permanent. With mania being a typical mixed or dysphoric during adolescence, it makes the process of diagnosing more difficult. Many patients experience a delay between the onset of their first symptoms and their diagnosis with BPD. One study demonstrated that 53% correctly diagnosed patients with BPD received their diagnosis within the first year, while the remaining patients on average waited 7.5 years to be correctly diagnosed with BPD. This demonstrates the issue that is observed when diagnosing BPD. It has been found that young children have been prescribed multiple psychotropic medications. 80% of preschool children were receiving antipsychotic medications also were prescribed other psychotropic medications to manage their symptoms. The reasons for the rising trend in the use of antipsychotic medications can be because of the greater acceptability of psychotropic medication use in children, increased knowledge and awareness, limited access to non-pharmacological treatments such as therapy, demand for quick and affordable treatments, and inadequate provider time. Potential argument to use medication to treat BPD is that BPD affects the brain chemistry, and so some believe that only medication can target these areas to help balance out the brain chemistry that is out of balance. Another reason why medication may be a better option for children with bipolar disorder is due to the demand for a quick and affordable treatment. People turn to medications instead of therapy as an early intervention during childhood to better increase the odds in adulthood, and so it becomes used as a quick fix. On the other hand, there are repercussions for prescribing antipsychotic medications to children. Most child psychiatry is off-label because people do not want to have their kids as the test subjects. SSRI antidepressants PACs will cause the concern over increased suicide risk in children and adolescents and create the implementation of the black box warning on antidepressant medications that warns that it may increase suicidal thoughts and behaviors. After being on medications for many years, it can lead to being overweight, high blood pressure, and risk of diabetes, and some can develop other side effects that may not go away when the medicine is stopped, such as tardive dyskinesia. Therefore, children need to be constantly monitored on them, whether it's their weight or their blood levels, to make sure it is not harming them. There's no specific timeline of how long to keep someone on antidepressants for someone with BPD, especially after symptoms resolve. One study conducted comparing risperidol to olanzapine showed that over the span of 6 weeks, preschool children gained an average of 6 pounds. There are evidence-based alternatives that can be used to combat the symptoms that a child is experiencing if they do show signs of BPD. Adult literature suggested psychoeducation, family and individual interpersonal and social rhythm therapies is best supported in addition to medications. According to research on expressed emotion, family dynamics have a moderating effect on treatment response and recurrence rates. In conclusion, antipsychotic medications should be last resort after parenting skills training and other behavioral treatments have been tried and failed. Alternative evidence-based approaches like psychoeducation, family and individual interpersonal and social rhythm therapies are best used to treat BPD. Thank you. That is my presentation.